On the Drugs tab, Antiarrhythmic Drug Actions note. The FDA has a black box warning against the use of flecainide in MI and scarred tissue. It's a proarrhythmic in those subset of patients, MI or scarred tissue. We call those structural conditions. I want you to note that MI is one thing, an old infarction for the sake of arrhythmic mechanisms of action, and an ongoing acute ischemia is another thing, because the scarred fixed structural tissue might cause re-entry and monomorphic tachycardias, whereas the active ongoing ischemia with disruption of propagation of electrical wave fronts can have polymorphic tachycardia. Mechanisms of proarrhythmic actions are three. We have the slow conduction and prolongation of repolarization and calcium overload with delayed after depolarization. Let's take the first one. Slow conduction. At slower heart rate, there's reverse use dependency, meaning dependent on the lack of use to induce arrhythmia. The lack of use of what? Not the medication, but the channel. The ion channel is not being used, so it is not in the active form. And that promotes re-entry. We see that frequently with class 1C. That's why I started with flecainide, the black box warning, because this is a class 1C antiarrhythmic medication according to the von Willebrand classification. Re-entry, those are monomorphic. They go round and round and round through the same route as long as there's an excitable gap that allows the electricity to re-enter and continue the tachycardia. The propagation of repolarization, prolongation of repolarization, you have to have a long QT for this subset of medications. But technically, if you have a prolonged QRS, then that contributes to the QT because the QT is the total duration of ventricular excitation or ventricular contraction, really. Total duration of systole, of ventricular systole, actually. So that includes depolarization and repolarization. But for this mechanism, we're talking about the repolarization part of the action potential. And delaying that is seen mostly with class 3 agents. There is a little bit of contribution with class 1A medications to the prolongation of repolarization in addition to prolongation of depolarization, which is their main activity. So again, let's talk about it in terms of channels. Remember, the slow conduction had lack of use of ion channels, i.e. in bradycardia, resting heart rate, that promotes the tachyarrhythmia. We call that phenomenon reverse use dependency. We'll discuss its physiology below. Now, let's talk about ion channels here. Class 3, they're usually potassium, and potassium, they come in the later downsloping part of the action potential where you have repolarization. And then, of course, the refractory period. A note I want to make about repolarization and refractory period. Repolarization is not returning the membrane to its baseline. Repolarization is returning the electricity to baseline, and then the refractory period will correct the gradients, will correct the right type of positive ions in or out. Meaning, when I depolarize my action potential, my membrane potential, it goes in the positive direction. And then I try to repolarize, I try to bring it back to the negative, but what I am doing is I am kicking in and out sodium and potassium. Sodium should be more outside the cell and potassium should be more inside the cell. And the refractory period, well, after returning the electricity to baseline, the concentrations are not correct. So the refractory period kind of corrects the concentrations in preparation for the next action potential. However, not always do we have the refractory period successfully finishing its refraction in all the tissues because the different levels of the heart have different levels of depolarizations and repolarization temporally in terms of time, so they don't overlap perfectly still. And that's because once a tissue excites upstream of the wave, it needs the next tissue to be ready for excitation to give that wavefront to it. So they should not, ideally, be all repolarizing and depolarizing, then going in refractory and absolute refractory at the same time, because that would necessarily mean there is no electrical conduction. The third mechanism of proarrhythmia, so those are the mechanisms of proarrhythmia: slow conduction, prolongation of repolarization is the second one, and it will give us polymorphic VTs. Now, the third one is calcium overload. Now, this will also give us polymorphic VTs, but it's a bidirectional polymorphic VT. And the primary concept behind calcium overload is calcium overload behind this phenomenon is delayed after depolarization. So, again, prolongation of repolarization will be a phenomenon that is related to prolongation of QT, and whereas the calcium one will be a phenomenon due to increased calcium concentration in the cytosol. That means either outside the the sarcoplasmic reticulum, or inside the cytosol from the outer membrane. So you bring in calcium either from the extracellular compartment or from the sarcoplasmic reticulum compartment. The classes of medications, now they are multiple according to the von William. There's class 1 antiarrhythmic drugs, and there's class 3. Those are the ones that are actually important and are truly antiarrhythmic, because beta blockers and calcium channel blockers and glycosides are not really considered and don't exhibit the same effects on the cardiac action potential, because they do slow down and they have effects on ionotropy, so not just coronotropy. But the true antiarrhythmic drug medications are class 1 and class 3. So we'll focus on those. It is absolutely a must to memorize the class of drugs because of their action on QT, class 3, or the QRS, class 1. And that will determine A, the indications of use, such as someone with polymorphic or monomorphic, or someone with an underlying channelopathy, right? So you try to block or excite the channel depending on the function. Someone with a structural heart disease. And C, of course, the function of the medication, all by means of QRS prolongation, again, class 1, or QT prolongation, class 3. And of course, we have Venetian class 1A, where there's a little bit of contribution to QT prolongation as well. And that's in relation, all of that, either QRS prolongation or QT prolongation, all of that needs to be understood in relation to use and reverse use dependency. Not the use of the medication, the use of the channel upon which the medication is acting. What uses the channel is the heart, not us as clinicians. That's the pathology itself that's exciting the channel, or the physiology. Channel is in sinus rhythm, patient is sleeping, it is in relative bradycardia, or there is a bradycardic pathology. These all are states of reverse use. Or if it's actively being used, then that would be a channel that is in use. A use-dependent drug means a drug that will work better in tachycardia because the channel is used, and a reverse use drug will be better at slower heart rates. So classes, let's talk about class 1. Class 1 automatically means sodium. Class 3 automatically means potassium. Sodium channels, potassium channels, sodium currents, potassium currents. The sodium currents act in phase 0. It's phase 0 predominance. It is the depolarization front. So the major effect is on depolarization. Generally are use dependent. They work better at faster heart rates. Propafenone is the class 1C, and it is a pill in the pocket for atrial fibrillation because atria are hyperactive. A note on propafenone is that it can organize a fast atrial fibrillation, slow down the atria just enough, and cause excessive conduction to the ventricles. And so because AFib actually is atria in very fast heart rates, we're talking about 250s more, You organize it to atrial flutter, it comes down to 150 to 180, 200. It really isn't that big of a deal. It's still going to be fast. It's still going to act well because the channels are still being used and still being used very robustly. So there is a good use dependence. So what do I do to prevent propagation to the ventricle and having a VT when I'm trying to stop AF? I'm trying to help my patient. I don't want to make them worse. I give them beta blocker ahead of time. And so the idea that propafenone is a pill in the pocket approach, it should be a 2 pills in the pocket approach. You give the patient a beta blocker, tell them once they start feeling symptoms, they take the beta blocker first, and then if they can wait for 20 to 30 minutes, they take the propafenone at that time. The beta blockers won't slow the atria enough in any way to prevent the use dependency. Okay, so that was just a clinical caveat, and the reason we're putting them here is to try to correlate things with what we're talking about and make the concepts clearer. But we will discuss those in more details in each drug alone. Class 3 are the potassium. They're phase 3 predominant. The phase 3 is the plateau phase and the downsloping phase. And it is potassium a major effect on repolarization. And the reason why I say phase 3, oh no, phase 2, oh no, phase 3, potassium, plateau, downsloping, because you have potassium channels here and there. One of them is slow and one of them is fast. The IKR and the IKS, the slow and the rapid IKR, fast channel. And so the class 3 medications will affect those. I'll discuss those a little bit. And we have a lot more potassium channels as well as such as the catecholinergic one, the IKACH. There's a note about that in the atria. But let's talk about the main idea with class 3 is that they are reverse use dependent. So they're not the same as class 1. They're the opposite. They're the ones that'll work better at slower heart rates. So if I give propafenone to stop an atrial fibrillation in use, right, in use dependency in fast heart rate, then I can give amiodarone to maintain sinus rhythm because that'll work at the slower rates and it'll prevent arrhythmia. And so it helps at rhythms with normal or slow heart rates. The classification of antiarrhythmic medications is based on the QT interval, right? They're based on the QT interval in general, the von Willebrand classification. The sinoatrial node action potential, there are less sodium channels in the upsloping limb in the sinus node. And so the sinus slopes here are more blunt. Some of the figures, all the figures in blue here are taken from the Mayo Clinic Board Review course. I highly recommend that you buy and read that. The atrial myocyte, there are more potassium catecholinergic potassium IKACH channels in the downsloping limb. So this leads to particularly slow action potential both in the up and the lower slopes. And then it gives you this upsloping refractory period in the phase 4, and that leads to automaticity. And so, but what that does is, if I have a particularly slow action potential, then that gives me more opportunity for re-entry because of the refractory period, because depolarization can happen early, and inappropriate excitable gaps. Those are issues that did appear in previous exams on MCQs, whether on boards or in question banks. So you see the atria. The sodium channels are absent. The pacemaker current is slower, and we have different potassium channels here, and we have a slower up and lower slope. As you go down to atrial myocyte, and you're getting out of the sinus node, which is autonomous, you have the IKR present and the catecholinergic potassium channel present. And what that does, it gives us a slow downsloping limb. See the slurring there. And that will also be particularly important for opportunities of re-entry in the atria. And the AV node again works similarly to the SA node with the absent sodium channels. So you should think that class 1 medications will not work all that well on the sinoatrial node and the AV node. And then you see there are different morphologies of the different levels of the myocytes, and the epicardial myocytes are usually slightly shorter. The myocardial, the middle part where the muscle really needs to contract, are the longest action potential. And the endocardium are relatively shorter, but more than the epicardium. And that helps with ECG propagation. We'll discuss that in a different note. Similar to the sinoatrial node, AV node also has absent sodium channels. So this is the highlight. And the AV node and SA node will both not have a lot of activity or a lot of response to class 1 medications. Purkinje fibers are longer duration, and this is by design. The idea to have the Purkinje fiber being long is to prevent re-entry. So the channels are all occupied, and that means that a new wave front cannot start. So that prevents re-entry by making very small room for an excitable gap. Re-entry in this case will lead to fascicular ventricular tachycardia because you're at the levels of the fascicles where the Purkinje fibers exist, slightly below the main bundle trunks, and that can lead to fascicular VT. And so just to think, when you're looking at an ECG, if you suspect this is fascicular, you can think of the mechanism. The ventricular myocardium has variable action potentials. Action potential between epicardium and the myocardium is different. So in the epicardium is different from the myocardial action potential, which is similar but still slightly different from the endocardial action potential. This can also explain why when you have pathologies or edemas or electrolyte disturbances, then you can have those polymorphic ventricular tachycardias. The variation in action potentials described above are due to variables in the ITO potassium channel density that's in the myocardium. And so this is the transient potassium current, transient outflow, TO, transient outflow potassium current channel, which shapes the repolarization curve starting from phase 1. So you have those. Again, this is from the Mayo Review Board. It was a lecture by Dr. Noseworthy. Absolutely amazing lecture. We have the sodium channels, the ITO potassium channels, and the ITO potassium channels work in this phase, and then that connects with the other potassium channels. And so transient outflow potassium current channel shape the repolarization. They start in phase 1. So phase 1 is this one, whereas phase 0 will be the sodium ion channels, the INA. This variability is substrate for torsade de pointe in the right conduction setting, which is long QT, and that will lead to early after depolarization. So long QT due to the prolongation of this phase, and you have a potassium channel that's working here, and it starts here in phase 1 and then goes down, prolongs the QT, and that as you prolong the QT, you can have propensity for more after depolarization, which will occur in this area. QRS prolongs in medications of class 1, but not necessarily the QT. This is an MCQ question. If QT prolongs, it will only prolong with class 1A, but slightly less than 3. 1B medications can potentially decrease the QT. You see here, class 1A, 1B, and then 1C. So these can potentially decrease the QT, but they have very little effect on the duration of QRS potential and on the action potential duration, and that makes them an excellent choice for ischemia and structural heart disease, but mainly ischemia, active ischemic patients, the ones in the ICU, the ones who are not doing well. Class 1A medications are the weirdest. They have mixed effect on phase 0 and phase 3. That is why amiodarone is the weirdest of all of them, because it is a class 3, but it also classifies as a 1A medication. And so it's the weirdest altogether. It increases QRS as mentioned above, making it a class 1A, and it increases QT by affecting the potassium channels, and that makes it class 3, which is the period of the total ventricular contraction. Again, the QT includes the QRS. Whenever you have a prolonged QRS, the QT will increase. In fact, in ECG coding, when you have bundle branch blocks and wide conduction delays, wide QRSs, in addition to correcting the QTC, you have to correct for wide QRS to get your real QTC, corrected QTC. So 1A medications, their pro-arrhythmic effect is torsade de pointes. Historically, quinidine used to be titrated until the patient developed syncope. What actually was happening is that the patients developed torsade de pointes. Obviously, we don't do this anymore because we don't want our patient to fall. I'll discuss a little bit more about that later on. Procainamide can cause torsade de pointes specifically in renal patients. So these are, again, 1A. Renal patients. This is a very commonly tested fact on the boards because procainamide metabolized in the liver will give a metabolite called NAPA, N-A-P-A, which is N-acetylprocainamide. And NAPA is renally excreted. And thus, in renal impairment, the patient gets toxicity similar to that of class 3 and will lead to torsade de pointes. You see the torsade de pointes is here. You have an early after depolarization. On the T wave, you have a PVC that starts or that really potentiates the arrhythmia. It falls at the end of the T wave. It gets closer into the T wave, and as it gets to that closer opportune time, then it's going to fire up a torsade de pointes. Disopyramide, that has a niche indication for hook'em, is a class 1A, but it has a niche indication for hook'em with atrial fibrillation. This is occasionally tested on the boards because it is also a negative ionotrope, so it helps with overcoming LV outflow tract obstruction by decreasing the LV-OT gradient. It has negative ionotropy effects to the reduction of the force of contraction of the heart muscle. In hypertrophic obstructive cardiomyopathy, the left ventricular outflow tract gradient is caused by the dynamic obstruction of the LVOT due to the systolic anterior motion known as SAM, S-A-M, of the mitral valve. The SAM is caused by the drag forces that are generated by the flow of blood through the LVOT. Negative ionotropic agents such as disopyramide can reduce the drag forces by decreasing the contractility of the heart muscles. This reduction in contractility can lead to a decrease in the LVOT gradient and an improvement in symptoms. However, negative ionotropic agents should be used with caution in patients with hook'em because they can cause hypotension and bradycardia. And remember, in general, you want to fill up the ventricle, so you want to give the ventricle enough time and you want to relax it. If it fills up, then you have less LVOT obstruction. Class 1B medications, they are inactive state dependent. Remember, they have little effect on the QRS and the action potential duration. That's because they are inactive state dependent. So state dependency will be discussed later. Inactive channels is a state of recently engaged channels between activity and rest. There are more inactive sodium channels in acute ischemia, and that's why we like to give it an ischemia, an active ischemia, giving them their specific indication for ischemic VT, relatively little use dependency, least pro-arrhythmic effect. Their problem is that they unbind quickly. And so class 1B have rapid kinetics in the myocardium. Lidocaine is our IV formulation. Mexiletine is technically lidocaine is just the oral formulation. And that is a commonly tested fact on the board as well. They are the drug of choice, the 1Bs, in injured myocardium, whether it's myocarditis or acute ischemia, and the patient is critically ill in acute state because the ion channels are in their inactive state. In fact, they work exceptionally well in injured myocardium, and they have very little proarrhythmic effect because they have little effect on the QRS. And so to be able to potentiate proarrhythmia, you need to change the electrical wavefront in a way that would allow for excitation and a new action potential to occur in the wrong time and potentiate a proarrhythmia, and that would be a focus of proarrhythmia. Class 1B are frequently used in CCU for ischemic patients. When you get the question on the exam, usually they'll give you a vignette that tells you, they may not want to tell you the full history and the patient came with a mild, they'll just tell you they're in the ICU, they have this ECG at baseline, they have this ECG or rhythm strip now, they're on ionotropic support, blah, 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 they've been admitted for a few days or whatever. Or maybe the question will tell you the ICU calls you. And so the idea is that by looking at the old ECG or the baseline ECG, you recognize there was an ischemic insult. Looking at the rhythm strip, you recognize there's an arrhythmic issue, a new arrhythmia, and then you'll opt for class 1B medication. For class 1C medication, monitoring, example, to make sure that you won't go into fleca flutter, which is the phenomenon that we described at the beginning of this note, that you slow down the atrial fibrillation a little bit, and it might organize into coarse fib or flutter, and that will potentiate conduction down to the ventricles and cause ventricular tachycardia. That is conduction 1-to-1 with atrial flutter. It is colloquially known as fleca flutter. That's not an official terminology, but it's used in the wards. So in this case, you want to stop the agent that you're using, flecainide, fleca from flecainide, right? If you're using flecainide, stop it, but you don't start any other 1C medication. So stop the 1C agents altogether if the QRS prolongs by more than 25% of the baseline, even before you have an arrhythmia. Acceptable therapeutic prolongation is usually 10%. And monitoring will be by serial ECGs and monitoring the QRS duration. In general, the QRS prolongation happens when the heart rate is fast. Why? Again, because of use dependency. Again, because this is a sodium channel medication. You can even stress test the patient to see if their QRS prolongs to initiate this medication. And this was used to be historically done more. We still use it. Just don't let the patient fall. Once you have the prolongation, enough prolongation of the QRS, you stop the test. You know that they're not candidate for 1C. So decreased hepatic metabolism of propafenone, the other 1C medication. So we just discussed flecainide. Propafenone is the other 1C. It's really the same for flecainide, but more pronounced for propafenone. And propafenone is the one that is usually tested for this fact, the metabolism fact. It occurs in 7% of people who are slow metabolizers. The reason we ask about propafenone, even though flecainide has the same effect with metabolism through the same cytochromes, because propafenone was studied and we have epidemiologic numbers. So 7% of people with propafenone have slow metabolism of propafenone. They're slow metabolizers due to their inherent mutation or difference in the cytochrome P2D6. Cytochrome 2D6. And that will lead to bradycardia and broad QRS toxicity. Slow metabolism means higher level of medication means medication toxicity. Higher level of medication means medication toxicity. The cytochrome is cytochrome P2D6. Of interest is that these 1C medications have structurally similar to propranolol, which is a weakly functional, they have weakly functional structural similarity. And I found that in one MCQ. It's not really that important. Don't switch from propafenone to flecainide, must switch out of the class altogether. This is very important and can be tricky. If you give flecainide, give it with beta blockers to avoid the 1-to-1 conduction, and fast ventricular response, very testable on the board. So from propranolol, they're usually given as non-selective for migraines or hyperthyroid, and the hyperthyroid patient will have more use dependency, more propensity for arrhythmia. So you want to be careful for that. Whereas the beta blockers we use are selective beta blockers. We like to give metoprolol, succinate, or bisoprolol or carvedilol if there is a component of hypertension. For the so flecainide, give with beta blockers. Remember the pill in the pocket approach that we discussed with propafenone also should be called the 2-pill in the pocket approach. You ask the patient to take the beta blocker and the flecainide to prevent the conduction to the ventricles by slowing the ventricular entry or the AV node, and then you give the flecainide to slow the fast atrial activity that is use dependent. Class 3 medications, they have no effect on phase 0, right, except for amiodarone. But the rest have no effect on phase 0, and this is an MCQ question. They're good for rhythm maintenance, not good for pill-in-the-pocket approach. Why? Because they're reverse use dependent. You're not gonna terminate a fast arrhythmia. But they'll work better when you are in bradyarrhythmia or in lower rates, normal rates. They prolong QT. Any medication that prolongs QT in general, will exhibit reverse use dependency. Now, class 3 agents, they are potassium channel blockers, particularly affect the IKR. So the IKR works in this range here, right, more towards the end of the action potential, the downsloping part, so in the phase 3 part of the action potential. And look at the graph above to see that, yep, sure. The inward rectifier rapid ion channel, so the K stands for, the IKR stands for the rectifier rapid channel, the potassium, inward potassium rectifier channel. And just for comparison's sake, the IKS is the inward rectifier slow channel. And that's important because if you act on multiple channels, you can have different effects. But for class 3, they mainly act on IKR. We'll discuss that in a bit about the IKS. Monitoring the drug will sensibly be monitoring the QT interval at rest. And rest is important because it's reverse use dependent and in sinus rhythm. This explains why the highest potential for proarrhythmia with class 3 is in bradycardia. The clinical vignette you will get is someone with sleep apnea or someone who is taking these medications and has sinus pauses or bradyarrhythmia. And usually the question will ask you about a patient who's sleeping. So let's just read that. There's potential for interaction between dofetilide and beta blockers. That's also why most calls from telemetry nurses, so the beta blockers slow the heart down, dofetilide is class 3, reverse use dependency, a lot of beta blocker will cause arrhythmia. You get a call from the nurse at night for polymorphic torsadepine on the rhythm monitor, for a patient on dofetilide or any other class 3 really, sotalol for example. And the patient has been sleeping, they're asymptomatic, but the nurse freaks out, she calls you or he calls you, and a potential for pause-dependent VT, usually a sleep apnea patient on dofetilide or sotalol, or having an AV node blocking agent or an agent that will slow down the heart rate. Note that amiodarone is much less common, if at all, to cause this because it has effects. It has multiple effects. We'll see that. We'll talk about that in a bit below. The patient is sleeping, develops pause or bradycardia, this is the mechanism, or even atrial fibrillation, and converts to sinus rhythm. So he was in atrial fibrillation, converts to sinus rhythm, or relative sinus bradycardia, or sinus bradycardia, that promotes entry. So that could be another question in the exam, where you're given a class 3 medication, the patient was in atrial fibrillation, they cardioverted spontaneously or with help, but then shortly after they developed torsade de pointes after a period of bradycardia. That will be this mechanism. So reverse use dependency works better at slower heart rates when the IKR, the rapid rectifier potassium channels, makes meaningful contribution to the total magnitude of ion transport. And so you see, while the ion channels are being activated at certain rates, one channel will be more meaningful in terms of amplitude and will predominate the action of the electrical action of the action potential, and that's why blocking it at that rate will have the biggest antiarrhythmic action from the antiarrhythmic medication and will explain the proarrhythmic action of these medications. So let's talk about the SWORD trial. The SWORD trial was published in The Lancet in 1996. There was a review article of it on the American Journal in 1998. I believe there was also a republication in 2001. This is an important trial, proarrhythmic effect post-MI. It stands for Survival with Oral D-Sotalol trial, or known as the SWORD, which was a clinical trial conducted to test the hypothesis that class 3 antiarrhythmic agents, mainly D-Sotalol in this case, would reduce all-cause mortality in high-risk survivors of acute myocardial infarction. Take note that in real practice we use D and L-Sotalol. You can't control the isotype, but in that drug they had a meticulous method, and they wanted to specifically to use D-Sotalol. The study enrolled more than 3,000 men and women with ejection fraction less than 40%, because we're looking for the ones that have heart disease who survived acute MI. So there's an ischemic cardiomyopathy here, or ischemic dysfunction that is post-myocardial infarction, and the duration they allowed in their inclusion criteria was 6 to 42 days, or remote myocardial infarction more than 42 days, and that was analyzed for the duration, with overt class 2 or 3 heart failure, but not class 4, and not patients who are asymptomatic. The trial found that the death rate was 5% among half the patients assigned D-Sotalol, compared to 3.1% to the other half, which were assigned to placebo. So the relative risk of death was 1.65 in the Sotalol treated group, which is with a 90% confidence interval, presumed due to arrhythmic deaths, and so accounts for increased mortality. Therefore, their hypothesis was proven wrong, and it turns out you should not give class 3 medications in this. So we already mentioned that the FDA warns against using the 1C medications, and the SWORD trial also tells you shy away from the class 3 medications unless you know what you're doing, and especially Sotalol. You don't want to use Sotalol per se. We're extrapolating the L-Sotalol to the D-Sotalol because so far their clinical function is the same. So the investigators indicate that prophylactic use of this potent antiarrhythmic agent does not reduce mortality in this patient population and may be associated with increased risk of death in patients with left ventricular systolic dysfunction after myocardial infarction. Okay, here's a question commonly tested. Why is amiodarone less proarrhythmic? That's because, remember, I told you we'll discuss the potassium rectifier slow channel. Now we're going to discuss it. It affects, because it is rate dependent, it affects the IKS and IKR. So its rate dependency, it works well in the IKS phase, and it works well in the IKR phase, and so it gives a longer duration of action that can include anywhere between the phase 2 and phase 3. And so making it neither use dependent nor reverse use dependent. That's why we give it this fancy name of rate dependency, because when it's working here, it's use dependent, and when it's working there, it's reverse use dependent. So that again explains why amiodarone. We said class 1A medications are weird drugs because they prolong both QT and QRS. Well, amiodarone is the weirdest of all because while it's a class 3 medication, it's also a class 1A medication. The 1A medications we said are the weirdest of all. So amiodarone is the weirdest drug of all because it's also a class 1A and it also class 1-3, and it has a specific use a state, or it has the specific terminology rate dependent, because it is neither use nor reverse use dependent. So, all right, the class 5 medication, there is it's a medication that we're concerned with, which is digoxin. It's a cardiac glycoside. It inhibits the sodium-potassium ATPase. To me, that's important because we know that one of the pro-arrhythmic medications, we already said that the most important ones are class 1 and class 3, but I want to include this one because the mechanisms of proarrhythmias include calcium overload, which will lead to bidirectional VT. And if you inhibit the sodium-potassium ATPase, that will inhibit the regulation of calcium currents into the cytosol relative to the extracellular compartment. So digoxin toxicity can lead to bidirectional VT. And so you have alternating QRS axes. That's what a bidirectional VT looks like. This is the classic look. So digoxin toxicity is bidirectional VT related to the sarcolemma, the outer membrane. The sodium-potassium exchanger is inhibited. Therefore, the calcium ion increases, the concentration of calcium increases in the cytosol. And the other way to increase calcium in the cytosol is not the sarcolemma, but from within, to get out that giant store of calcium that's stored into the sarcoplasmic reticulum, which is stored there for a reason. It releases for contraction, goes back in, releases for contraction, goes back in. That is how all our skeletal, or all our striated muscles, including cardiomyocytes, are designed. But what if they are leaky? What if they are giving off calcium and they're overloading the cytosol in the wrong part of the cardiac cycle? Well, CPVT is a condition, a catecholaminergic polymorphic ventricular tachycardia, that causes bidirectional VT by different mechanism than the one that we discussed. So the sarcoplasmic reticulum release of calcium into the cytosol can be triggered by anything that will promote the release. So remember, a sarcoplasmic reticulum will want to give calcium whenever there is a potential. Whenever the cardiomyocyte decides, okay, I want to initiate a contraction, but I'm going to release more calcium. And if I'm already leaky and already potentiated, and I go ahead and give an antitachycardia therapy by an ICD, or pace the patient at a faster rate, or even give something like isoproterenol to increase the heart rate, then anytime you increase the heart rate, there is a risk of bidirectional VT. So never prescribe device therapy for these patients. You never want to give them shock. You don't want to pace them. That's not the way to deal with CPVT. The way to deal with it is to give a calcium channel blocker. And so obviously exercise and stress will also give the same idea. They're going to potentiate more contraction, more action potentials, and there is more calcium ready in the cytosol, and so you can have this bidirectional VT with alternating QRS complex with every beat. It's an example of an underlying mechanism of delayed after depolarization. So the underlying mechanism is delayed after depolarization. Normally the calcium should be restored outside of the cytosol by here, but because we have a little bit of calcium here, then you can have it delayed after depolarization and potentiate a new tachyarrhythmia. Above is the action potential at the cellular level. This means the surface ECG. This means on the surface ECG in comparison. The action potential is on the cellular level. On the ECG, on the surface ECG, the depolarization comes after the T wave, but before the next T wave. So it's not going to overlie the T like we saw in the torsade de points earlier. So the depolarization occurs after complete repolarization. Hence, it's called delayed after depolarization. Okay. So the other thing is, unlike early after depolarization, it is not pause dependent. The CPVT mechanism of action, how it leaks, is because ryanodine receptor is defective. and so will cause leakiness from the sarcoplasmic reticulum into the cytosol. The spectrum of digoxin toxicity, let's go back to the digoxin, the one that will block the sarcolimal ATP. The spectrum of toxicity in general, this is just to link things together from other notes. In addition to, we're talking about the pro-arrhythmic effect and bidirectional VT, but remember the spectrum of digoxin toxicity includes high vagal tone, AV block, accelerated junctional rhythm, atrial tachycardia due to increased automaticity, right? So all of those things can happen. And if you block the AV, you can have accelerated junctional rhythm. If you're potentiating arrhythmia in the ventricles, you could probably do that in the atria as well, but by means of increasing automaticity because you have high calcium levels in the cytosol. Bidirectional VT, obviously, as we discussed, due to the increased automaticity due to that. So the bottom line is hypercalcemia and calcium overload will lead to delayed after depolarization. With delayed after depolarization, if you pace the patient, you will exacerbate the problem. The problem is calcium overload. Give calcium channel blockers. Seen in 2 cases before. PMVT, polymorphic tachycardia, in either digoxin toxicity, the case we discussed, or the other one is CPVT, also high yield question. So we're just gonna summarize that by saying give CCB for delayed after repolarization. Okay, that's an important. Okay, so now remember when I told you we're going to discuss what it means to have use dependent and reverse use dependent, just to clarify things, because we also talked about pause dependency in relation to use dependency, and we talked about rate dependency in relation to the lack of both. And this will explain why physiologically. Early after depolarization depends on ion channels that are engaged or recently engaged. So that is either the inactive state or the active state, but not the resting, right? And that explains the idea of pause dependency. So inactive state is recently engaged, and that's the source of a lot of confusion just because of the terminology. But just know that use dependency are related to the use of A, active channels, or I, inactive channels, because I channels have been recently engaged. So those will be the EAD drugs. Again, EAD will be use dependent. Early after depolarization, use dependent, will be the ion channel state active or the ion channel state inactive. Greater drug effect at faster heart rate. Whereas delayed after depolarization depend on the ion channels that are in the resting state, which we refer to as R, in the resting state. And those will be reverse use dependent, and they are associated with potassium blockers, and they are, we see that also with the calcium overload, and they have greater drug effect at slower heart rate. The drug binding or affinity is different in the different states for each drug class. And the binding rate constant for each class, and each drug will have a binding rate constant, which will change depending on the ion channel state, right? And so that binding constant, if it can't bind long enough to exert its pro-arrhythmic action because the channel is not in the favorable state most of the time, because remember, these are signal transduction pathways, and there's always conformational changes and states of the ion channels. The other thing that's important is that the common sense tells you I go from active to inactive to resting, right? But you can actually go both ways. And this is important as well. All right. And with antiarrhythmic drugs, you should know which ones are renally excreted. And this is commonly tested on the board because there's a liability and a legal issue if you do not check renal functions, especially before prescribing dofetilide. So dofetilide, digoxin, and sotalol, you must document renal function before. Sotalol is our preferred agent with cirrhotic patients. This is also frequently tested on the boards. You want to make sure that they don't have hepatorenal syndrome, and that's how the MCQ will come. It'll give you a patient who has liver disease, and they want you to think you're going to use sotalol, and they just give you a one-liner that without clearly mentioning it's hepatorenal, but you need to figure out this is a hepatorenal patient and not give sotalol. The straightforward question will be cirrhotic patient, give sotalol. Which antiarrhythmic drugs are hepatically excreted? Amiodarone is our most important one. Class 1B medications, the mexiletine and the lidocaine. And there is a really big problem here because we opt for it, we reach out for it in the ischemic patient. But if someone is having acute myocardial ischemia, frequently you're going to have acute heart failure, liver congestion, and deranged liver function. Or if they are shocking in cardiogenic shock, you can also have hepatic ischemia. So you have to be careful in these two scenarios where you have liver overload and dysfunction or hepatic ischemia due to cardiogenic shock to not give the 1B medication. So lidocaine toxicity includes ringing in the ears. That also appeared on an MCQ before. And mexiletine is the oral form of lidocaine. So non-dihydropyridine calcium channel blockers, the verapamil and diltiazem, are both hepatically excreted, and also is propafenone. Okay,